To start with some open surgery topics, and I will go on. Okay, again, no disclosures about this topic. So open conversion, in our experience, we're performing 111 patients and represented historically about 10% of our open thoracoabdominal experience. But if we observe the last year, in 2023, the conversion of previous failed TIVR represented about a half of patients that we treated open. So it's something that is really evolving and something that is much more important and more important in the last period. Of course, open conversion has some technical problems as compared to standard open thoracoabdominal repairs. Pulmonary adhesion lesions that should be very cautious in order to avoid pulmonary damage, and also got some problems with his mouth, please. It's coming, go and back, go and back. No.
All right, you have slow builds within them. So you have it then has a build.
If you provide me with the other. It's not going.
There you go.
Okay, thank you. Okay, so the second thing is stent graft management. Of course, in most of the occasions, we have partial excision, and the radical excision is usually only used for infection cases. The third thing is to perform some AAA sutures, including the stent graft and the aortic wall with the Teflon felt, and paying attention to include the metal struts inside the suture and not outside, because causing bleeding. So this is a typical case, a 63-year-old man that was treated initially in 2016 for with beaver, but then underwent multiple endovascular interventions in the next 2 years. And at the end, in 2020, he presented with a 14 evolving to an 18 centimeter symptomatic aneurysm with a left renal artery branch that was loosed initially during the first T-branch procedure, and the right renal that was very kinked, with stent completely collapsed inside the aneurysm lumen. And so the only solution was open conversion. Then you can see here thoracorenal laparotomy, lysis of adhesions, left heart bypass that we usually did in these cases, the proximal clamping and the proximal phase of the anastomosis with partial excision of the stent graft and AAA suture. After completion of the proximal anastomosis, we then move the clamp distally and open all the aneurysm. You can see here the very big, large aneurysm and removal of the thrombus, trying to identify the stents going into the visceral vessels, cutting the stents, so having partial excision also of the visceral stents, perfusion of the visceral vessels, removing of the stent graft, and then extending distally, performing the distal anastomosis with perfusion of all the visceral vessels, and at the end, separate reattachment of all the visceral vessels. And here you can see all the stent grafts that we removed during this intervention. So the patient was well, and this is a CT scan at 2 years. So in our experience, we have different indications to open conversion, including some that we can call disease-related indications like progression, endoleak, and also completion after frozen elephant trunk. And then we have some stent graft-related conversion that include endograft failure, rupture, infections, fistula, and retrograde dissections. So of course, the perioperative results include a mortality that is 11%, with a paraplegia that is 7%, that is quite higher as compared to normal standard open thoracoabdominal repair, but this is due exception for the mortality and morbidity related to the stent graft related indication, so the very high mortality that we can observe in infection, fistula cases, and retrograde aortic dissection cases. So in conclusion, of course, this is a very technical, demanding procedure and should be centralized in very high volume centers experience in open surgery. Thank you very much.